Welcome back, everyone, to the My Cancer, My Plan podcast series hosted by Men's Health Network. This is episode 2, titled Know Your Code, Biomarker and Genetic Testing 101. Today, we're going to hear from Dr. Katherine Baker and 2 cancer survivors, Michael Holtz and Jon Treffert. Let's get to it. Dr. Baker, thank you for making time for us on My Cancer, My Plan. Dr. Baker, when I'm asked about biomarkers and biomarker testing, as I'm out there doing our health education campaigns and that sort of thing, my standard answer is simple. These tests are the keys that unlock the lock for specialized forms of cancer treatment. And biomarker testing is important because not every key unlocks all locks, right?
Yes, exactly. That's a great analogy. When we talk about cancer today, we're not just talking about where cancer started, like lung or prostate or colon, but really about the biology of that cancer. So biomarkers and genetic testing help us understand what's driving cancer at a molecular level, which can completely change what treatments work best for a patient. So it's about making sure we're matching a patient with the right treatment right from the start.
So let's get something straight. What is the difference between genetic and genomic testing?
Great question. These two terms sound almost the same, but they look at completely different things. So genetic testing looks at the DNA that you were born with, which tells us if you inherited a change in a gene that could increase your risk for certain cancers. So an example of that is BRCA1 or BRCA2 in prostate or breast cancer. It's essentially about your family risk. Genomic testing, however, looks at the DNA in the tumor itself. So cancers develop mutations over time that are not inherited, but just happen as cells grow and change. These tumor changes help us to choose targeted treatments that are aimed at the cancer itself or clinical trials. An analogy of this is like if your body was a car, genetic testing looks under the hood to see how the car was built. But genomic testing looks at what's gone wrong after you've driven the car 100,000 miles, what's broken or needs repair.
I love that analogy because I make that analogy all the time when it comes to men taking care of their cars. They take better care of their cars than they do their bodies. So I love that analogy.
Yeah.
What do you say, speaking of men, what do you say to men who think that they don't need these tests? Men are notoriously bad about trying to cut costs and not wanting to go through any additional testing or that sort of thing. What do you say to them who they don't think they need these tests?
Yeah, I hear that a lot, especially from men who don't want to pursue another biopsy or a blood test to get tested for these things. But these tests are important, and they're not about finding problems, but about finding answers to help guide treatment and even help your family. So, for example, some men with prostate cancer may have inherited mutations that make certain treatments work better, or tell us if your relatives, like your children or siblings, need to get screened for certain types of cancer earlier. Skipping testing can mean A, missing out on treatments that are designed specifically for your type of cancer, and B, leading to potential risk for your family members that could also have these inherited gene mutations. It's not about more care or adding on costs. It's about better, more personalized care.
So what questions should men be asking a physician like yourself?
So you do not need to know all of the medical terms to ask a doctor about genetic and genomic testing. A few good questions to ask could be, have I had biomarker testing or genetic testing done for my cancer? What tests are recommended for my specific type of cancer? And if you haven't had testing, request the doctor to order it. I think it's also important to ask how the results of genomic or genetic testing might impact your treatment plan, and if any of your family members should get tested if you do have a positive result. And if anything isn't clear in the explanations, ask your doctor to explain it. Ask your doctor to explain it in plain language. You deserve to understand what's being tested and why.
Yeah, and that's why it's also so important for men to have advocates, whether it be a spouse, a family member, just somebody go with them to the doctor that will ask those questions, will take notes, because again, men are just notoriously bad about not doing that. Thank you, Dr. Baker, for your valuable insight. What is the best method for viewers to reach out to you or Tennessee Oncology?
Yeah, so in order to learn more about Tennessee Oncology, you can just Google our practice, and we should be the first thing that pops up. But if anyone wants to get in touch with me, feel free to shoot me an email. My email is kabaker@tnonc.com.
All right. Thank you, Dr. Baker. Talk to you soon. Joining me now are Michael Holtz and Jon Treffert. What were you told? And Michael, you can answer this question first. What were you told about your cancer when you were first diagnosed?
Basically that I had cancer, and here is the treatment plan. This was 13 years ago. FOLFOX, which is the chemotherapy treatment that I did, was at the time just 13 years old. It was the standard of treatment, and pretty much it was, this is the standard of care. This is what we're going to do. And, I was one of the lucky ones. First line treatment worked for me. And here I am 13 years later, 12 years of no evidence of disease, and, advocating, spending a lot of my time advocating on behalf of cancer patients and their families. So,
what about you, Jon?
Well, even though I spent 30 years building devices for treatment and detection of cancer, I was completely blindsided by bladder cancer. I discovered it in my urine, and which is the way that most folks unfortunately discover it. I had an endoscopic procedure to resect a tumor, and my urologist who did the surgery basically strongly recommended a radical cystectomy. So that involves removing the bladder and the prostate and typically lymph nodes and any connected plumbing. So that was sort of what I was preparing myself for at the time. But the pathology came back as muscle invasive, which is got a much poorer prognosis than the more common non-muscle invasive, that doesn't invade the bladder muscle and extend into other organs. So I had muscle invasive. And like you said, I had my first scan as a patient, and it found that the disease had spread to lymph nodes, which was actually missed on MR and CT. So I was looking at stage 3B or 4 muscle invasive disease. And potentially, again, my urologist had a surgical lens. He was looking at standard of care. But that's what I was looking at when I was diagnosed. Genomic testing to look for what kind of cancer I presented with and potential clinical trial options, either to include or exclude clinical trial options. Actually, there was while I was waiting for things to settle, I learned at the European Society of Medical Oncology meeting, I was diagnosed in September. In October, there was a meeting that this new treatment was presented, a clinical trial, so a doubling of overall survival with this new treatment. And my oncologist, we decided to proceed with that treatment. And about 4 cycles in, he ordered a tumor-informed circulating tumor DNA test. So it's a circulating tumor DNA test that's designed to look at 16 variants of my tumor genetics in the bloodstream. And as proud as I am of PET, I was amazed. This is detecting molecules in milliliters of blood of tumor DNA that when it dies, it gets shed into the bloodstream. And you can find minute amounts of this DNA in your bloodstream. And so I had that tumor-informed circulating tumor DNA, ctDNA test, and that actually came back negative. which was pretty huge news. And I came to learn that, in fact, it's been validated in a number of different cancers that it will find evidence of solid tumor anywhere in your system 3 months median, as long as 6 months before you would see it in imaging. So as a recurrence tool, and that's one of the primary concerns with muscle invasive cancer is recurrence. So I got introduced to that. And then shortly after that, my oncologist also had me do germline testing, genetic testing, which is looking for inherited mutations in genes that you may have that you could pass on, in my case, to my daughter. So we did germline testing to see if she needed to undergo any special screening based on what I had passed on her way. Turns out I did have a CHEK2 mutation, but the data showed that she doesn't need to get screened more often than she would for her age. But again, it was a very, very important test that a lot of folks don't take advantage of. I think as Dr. Baker had mentioned.
Yeah, and Michael, you mentioned to me biomarker testing wasn't available at the time you began your cancer journey. My question to you is, how might your care have been different if biomarker testing had been available?
I mean, I certainly think if biomarker testing had been available, it could have been less toxic. Fulfox, which includes oxaliplatin, is a very toxic platinum-based chemotherapy. And I have, side effects like neuropathy and hearing loss and, things that have happened to my body because of that treatment. And it's entirely possible that a different form of treatment would have been available had biomarker testing and genetic testing been available.
Right. What do you think are 3 questions that guys need to ask when they go back to their doctor for their next appointment?
I think for me, certainly is there a biomarker test for this cancer? You need to have that test. You need to know what are my treatment options, and then what could this treatment do to my body? Those in retrospect, those are the questions that I would want to know, and that I tell guys they need to ask all the time. But I think certainly in reference to this conversation, it absolutely is a genetic test available is a biomarker, is a genetic test available for this cancer type?
Jon, you want to add anything to that?
Yeah, no, I certainly agree. I think the genetic testing, like I say, the clinical trial that led to my treatment was announced at ESMO 2023. This year, there was an announcement that actually validated the use of ctDNA for clinical management. They showed that people that didn't need treatment were ctDNA negative, didn't need a treatment. And they showed that folks that required treatment, that positive ctDNA led to improved results. So having that as a tool, but also, very apropos to Michael's comment, 7 cycles into my treatment, I had developed a number of adverse effects, including some neuropathy. I'd lost my hair. I'd lost my sense of taste. But I had had serial ctDNA negative measurements. So that gave us the confidence to basically suspend the targeted chemo part of my treatment, but keep on with the immunotherapy. So it was a very important way to dose manage to make sure that you're not getting more than you need. And dose de-escalation is a huge component. Mm-hmm. But also, I think asking for both the genomic and the genetic testing to look at what the impact is for your offspring is one connection. And the other one is at ESMO this year, they also announced a targeted treatment that potentially offers an even higher level of complete response than mine. It actually may have lower adverse effects, but is targeted to a HER2 mutation. So if you have that genetic testing, you can know whether or not that's going to be effective. In my case, I have a related gene, which is an ERBB2, which is kind of HER2 related, but impact for me is that should I see recurrence, this might be an option that could be targeted based on my genetic.
Well, guys, I'm so grateful that you all could share your stories with me today, with us today. And I think the information you shared will certainly help someone in need. Tell the folks at home how they can reach you if they've got any questions.
My email address is mholtz@manuptocancer.org, and happy to help anytime.
And I have a website called TreffertInnovations.com, and I run a blog there where I basically detailed the whole history of my journey and try to make new advances and options available. So if you just go to TreffertInnovations.com/blog, you can reach me.
Thank you, Michael. Thank you, Jon. Yeah, we're very fortunate to have been able to have you.
Glad to be here.
All
Good
right.
to see you, John.
You guys are dismissed. Thank you.
We need to connect.
Thank you. Talk to you soon.
See you.
Okay, guys, here are a few helpful tips. Consider this your action checklist. When requesting biomarker or genetic testing, ask your healthcare provider if testing is appropriate for your condition or family history. They can order the test or refer you to a genetic counselor or specialist. Understanding those complicated insurance issues. Contact your insurance company before testing to confirm coverage or out-of-pocket costs and whether prior authorization is needed. Ask your provider's office for help with paperwork or appeals. Again, I'm going to say that one more time. Ask your provider's office for help with paperwork or appeals. And lastly, finding second opinions. Request copies of your medical records and test results. Then schedule an appointment with another specialist or major medical center. Many hospitals and cancer centers offer second opinion services, some of them even virtually, so you don't even have to leave your house. And our quote for the week is short and sweet. It's a proverb. Health is wealth. There is nothing more important in life than good health. Until next time, stay active, stay healthy, and always stay informed.